Hello, this is Dr. Jonas Van Oggs, and we will be discussing muscular dystrophy today. Our learning objectives are to appreciate the spectrum of muscular dystrophies, understand the pathophysiology and genetics of Duchenne muscular dystrophy and Becker muscular dystrophy, understand the natural course of Duchenne and Becker muscular dystrophy, and to understand the diagnosis and treatment of Duchenne and Becker muscular dystrophy. We will give you an introduction to muscular dystrophies and specifically discuss dystrophinopathies with epidemiology, pathogenesis and genetics, the natural history of the disease, diagnostic testing, management, and then finally, emerging therapies. Muscular dystrophies are a group of hereditary disorders of muscle. They affect individuals of all ages and have historically been classified by their pattern of weakness. For example, limb girdle and facioscapulohumeral dystrophies. Most are caused by defects in the muscle structural proteins. For example, the limb girdle muscular dystrophies can have defects in dystrophin, myofilin, lamin AC, calveolin, calpain, dysferlin, and sarcoglycan. Other examples of muscular dystrophies include myofibrillar myopathy, congenital myopathies, X-linked Emery-Dreifuss dystrophy, facioscapulohumeral dystrophy, scapuloperoneal syndromes, oropharyngeomuscular dystrophy, distal myopathies, and myotonic dystrophies. Due to the brief nature of this presentation, we will focus in more detail on dystrophinopathies, the most common causes of limb girdle muscular dystrophy. These diseases include Duchenne muscular dystrophy and Becker muscular dystrophy. Duchenne and Becker muscular dystrophies are degenerative diseases of muscle due to an absence or deficiency in dystrophin. The prevalence is 3 in 100,000 and occurs in 1 in 3,500 live births. Dystrophin is a protein that is encoded on the largest human gene, consisting of 2.5 million base pairs and 79 exons. It functions in the dystrophin glycoprotein complex as a structural protein that anchors the sarcolemma to the muscle cytoskeleton. It is coded on the X chromosome XP21 and is inherited in an X-linked recessive manner. The disease is expressed in boys, and up to 1/3 of the cases are sporadic. The two main phenotypes are Duchenne and Becker muscular dystrophies. In general, Duchenne is due to absent protein, and Becker is due to deficient protein. Absent protein is commonly caused by out-of-frame mutations, and deficient protein by in-frame mutations. The absent or reduced supportive dystrophin leaves the sarcolemma susceptible to damage. Excess calcium has access to the fibers and initiates cellular destruction. This eventually leads to replacement of muscle with fibrofatty tissue. In Duchenne muscular dystrophy, boys are born normal at birth. Typically, independent walking is delayed by several months. After starting ambulation, they are often noted to be quote-unquote toe walkers and have progressive lower extremity weakness. They develop lumbar lordosis and a waddling gait due to hip extensor weakness. Gowers Sign, a maneuver by which one stands by walking up the floor and one's legs with his hands, becomes apparent. They also have evidence of pseudohypertrophy of the calves, which is a representation of replacement of muscle with fibrofatty tissue. In development, they run, but are never able to jump off the ground. By age 5 to 6, they have difficulty climbing stairs. By age 6 to 7, they will start to have spontaneous falls and can be wheelchair-bound by 8 to 10 years of age. After loss of ambulation, contractures of the hips and knees become more severe, and equinovarus deformities can develop, accompanied by pain. Severe scoliosis typically develops, causing restrictive respiratory compromise, and cardiomyopathy is common and can predispose to arrhythmias. This affects 100% of individuals by age 18 years. Death is usually by respiratory or cardiac complications in the late 20s or early 30s. Because dystrophin is a protein present in the CNS, cognitive impairment and learning difficulties frequently accompany the disease. This is an illustration of the Gowers sign. Becker muscular dystrophy shares similar characteristics with Duchenne muscular dystrophy, but has a milder course. By definition, Duchenne patients are wheelchair-bound by age 13. Outliers are still walking by age 14. If they reach 16 years of age and are ambulatory, they are classified as Becker. Symptoms sometimes do not develop until the 4th decade of life. The weakness and contractions have a similar pattern. Leg cramps, especially with exercise, are more prominent, and a significant proportion of patients have cardiomyopathy, with some requiring transplantation. Diagnosis is commonly suspected by the development of clinical features in a male. The first test is usually a serum creatine phosphokinase, CPK, which can be markedly elevated to greater than 100,000 milliunits per microliter in Duchenne patients. Diagnosis can be confirmed with genetic testing. Other investigations include electromyography, which shows myopathic changes, muscle biopsy, which, although seldom performed now, shows variation in fiber size, fibrosis, and grouping of basophilic fibers and hyaline fibers. Dystrophin immunohistochemical staining is also available. Treatment is largely supportive, but there are emerging investigational therapies. Physical therapy and night splinting initially help to preserve range of motion and to prevent contractures. Bracing has been shown to delay progression to loss of ambulation by 2 years, but is cumbersome. Due to the pattern of weakness, the knee-foot orthotic is most helpful. Surgery in the form of tendinotomies of the Achilles tendons, knee flexors, hip flexors, and iliotibial bands with subsequent bracing may help to prolong ambulation. Scoliosis can develop in a significant number of patients once wheelchair-bound. Surgery helps to prevent pain and respiratory compromise, and it helps with patient comfort as well. Corticosteroid therapy with prednisone 0.75 milligrams per kilogram or deflazacort has been shown to prolong ambulation for up to 3 years, but is often not tolerated due to side effects. Genetic counseling should be considered to clarify recurrent risk and aid in identifying at-risk carriers. A small proportion of manifesting carriers will have elevated CPK levels, myalgias, and are at risk for cardiac disease. Cardiac and pulmonary referrals are recommended for most patients as the disease progresses, and these patients are best served in a MDA, multidisciplinary clinic, where their multiple needs will be served. Emerging therapies have been under development in this field. Myostatin inhibitors have been found to increase muscle mass in animals, and this is a possible venue for translational medicine. In select cases, the absence of dystrophin is due to a nonsense mutation producing a premature stop codon. Compounds are currently under investigation that promote ribosomal read-through of premature stop codons, resulting in production of full-length dystrophin. Another approach currently under investigation involves the use of antisense oligonucleotides to alter the pre-mRNA splicing machinery at the mutation site. This restores the downstream reading frame, quote-unquote, exon skipping. Gene therapy is continually under development as well, primarily with viral vector-mediated delivery of genetic material into muscle cells. Significant hurdles still exist with this approach, including delivery methods, host immune response, and the large size of the dystrophin. Smaller, quote, mini and microdystrophin constructs have been developed. These supply the critical genetic material in a size small enough to be incorporated into the vector. Techniques to increase the production of utrophin, a stabilizing compound homologous to dystrophin, are underway. Finally, investigation using stem cell therapies are in progress as well. In conclusion, muscular dystrophies comprise a large and heterogeneous group of genetic disorders characterized by progressive weakness. Duchenne muscular dystrophy is a severe genetic X-linked recessive disease that affects boys. Management currently is largely supportive, but steroids may help. A multidisciplinary approach is required to manage medical, musculoskeletal, respiratory, cardiac, and cognitive issues. Therapies are emerging that have the potential to revolutionize this field. These are our references.